Good morning and welcome to our monthly webcast. I am Samir Mehta. This is session number 28 and the 13th session since our partnership with theheart.org. I'm delighted to welcome you all. We have a very exciting, a unique and challenging case today, and without any delay, let me take you to the cardiac catheterization laboratory where Dr. Sharma and Dr. Kinney are all scrubbed and ready to do this procedure. Good morning, Samin.
Good morning.
What is all this? Am I seeing you at Mount Sinai or is this North Shore Hospital?
Well, let's put it this way, that I'm at Sinai and I'll be at Sinai for good. Now for 10 years. I know there were a lot of things happen in last 2.5, 3 months, but last week, after various negotiations and so, that I signed that I'll stay and probably will retire from Sinai. So I'll stay here, so that not going anywhere.
This is good to know, and I'm sure it's a relief to a lot of staff, the hospital and your patients.
Absolutely, absolutely. And I'm very happy that things could work out, because this was kind of my place. So much, started my fellowship being free and built this lab from just 300, 400 cases to this 6,000 and making a #1 volume, and as well as the safety point of view in the country, and really proud of it, and I'm so glad that it could happen, that things could work out here at Sinai.
So almost what, 25 years at Mount Sinai?
That is correct, and counting.
All right, excellent. Samin, what do you have in store for us today?
Great, this is actually the vein graft, and there have been a lot of demands, requests actually about the vein graft or the LIMA cases, and happened to be the LIMA patient. We felt that it will be a right for our monthly webcast. We actually have not shown of this series so far the vein graft case, but this one will be the LIMA intervention.
And definitely no LIMA intervention till today.
Absolutely, absolutely. Now this particular case, as you can see, if we can get to the slide, this patient has 2 bypasses in 1985, LIMA to LED and SVG to RCA, and then presented with crescendo angina back in June with class 2 symptoms, and has a stress MPI with a severe ischemia with a high risk scan, normal ejection fraction, and patient has hyperlipidemia, hypertension usual, and on good medical therapy, and basically showed that has a 3 vessel and left main disease with the distal left main about 80%, LED is total, fills via LIMA, and there is a significant lesion in the LAD after the LIMA anastomosis. So the mid to distal LAD has a 80-90% lesion. That will be our vessel in question today and treatment. And then she also has the lesion in the circumflex, which we intervened. And RCA is 100%, and there is a graft to the RCA, which has moderate disease. So basically that time we did an intervention of the circumflex, and Anu will take us through was a little complication and where we are now for this PCI of the mid to distal LAD via LIMA, and clearly that even for the vein graft intervention, our appropriateness criteria remains the same, that you need to show ischemia or positive stress test. Finding a lesion alone for in asymptomatic patient would not make it. This particular case, because of the symptoms and high risk scan, really qualifies to be appropriate. Now, Anu?
Samin, a quick question for you. Of course, it will be fascinating to see the Joe stent and how it looks after this period. Did the patient undergo a second stress test after her previous intervention in June?
No. Actually, the patient has been fine, except still have exertional shortness of breath. But angina, which she had, that disappeared. And that's a very big question, comes all the time. When you plan a stage intervention, are you allowed, as you know, that majority of the insurance carriers actually do not even allow us to do a second stress test because of the rules, regulations. And in this particular case, situation is a little different. Many times happens, you have a 95% circ and 70%, 80% LAD. Now patient has an infralateral ischemia, you're taken care of the circumflex, but LAD has a significant lesion, but did not show up on the stress test. And therefore the always question comes, what to do? In this particular case, the difference is, in this particular case, patient actually had both anterior as well as the lateral wall ischemia. So that we actually have the documented this patient was ischemic in both in the LAD as well as circumflex territory.
You can see the angiogram. This is the native. I think the left main circ stent looks okay, and this is what actually was shown during our June, I think, symposium. What had happened, she had a circumflex stent a few weeks before, and when she presented to us on that time, that she had a fistula connection between the distal circ LPL going to her great cardiac vein, and that's when we had tried to see how we can close it by using Geomed, where we could not get any stent past the proximal portion of the circumflex, and we had to do multiple coils, and that particular portion is now completely occluded, and the stent still looks patent. And this is our LV function, which is near normal. Native right
Anu, was the obtuse marginal branch, the ostium done at that time?
No.
No.
Yeah, there is a new lesion now. Yeah, kind of plaque prolapse into the OM1. Yeah.
Now, this is another part that we need to tell you, that when we are doing a bypass case, what we do is finish your left system, one cranial and one caudal, one cranial picture, and then when you go with the right coronary artery, you do your LV gram, do your native right, and start looking for the vein graft. Same thing with the Judkins right. We could not engage her vein graft to the right coronary artery, and we know that she does not have any other vein graft. So then you have to change your catheters to either some kind of Amplatz catheter. So before you do that, you would make sure you take a LIMA picture, and this is what we recommend, is that you get into your subclavian, and the same thing that subclavian, the left subclavian is the third that comes out of the arch. So as you keep pulling back, clock and keep pulling back, you get into your subclavian. As long as you know your pressure, there is no pressure damping, which means there is no subclavian plaque. You do a non-selective picture, which will give you an idea exactly where the LIMA is originating. And we also know that there is never disease at the LIMA at the origin. And if you see here, LIMA origin is most of the time is from the first 1/3 of the subclavian. It is diagonally opposite to the vertebral artery, but here it is coming off almost the takeoff of the subclavian, means in the not in the horizontal but in the upward portion of the subclavian. And if once you done your non-selective picture, then you go to your epicranial and still non-selective and inject hard, you will be able to see your LIMA attachment to the LAD. And this is the case that once we know there is disease, or you have a patient that has come to you with the stress test that is positive, then you can think of going and engaging the LIMA selectively, which many times you may need a wire to negotiate the catheter, which is the Judkins, to the subclavian. Then you counter and keep pulling back till you engage into the LIMA.
You have some question, Samir?
Yes, normally I like to use the multi-purpose for cannulating the vein graft to the right. You prefer Amplatz? Is that
the reason? Is to say multi-purpose will selectively go to the right-sided grafts, which could be the right graft going to the native right, or if you have a graft that is going to a dominant circumflex. If you use AR2, you can engage it to all the other grafts, either diagonal, OM, those kind of graft. And also it's important that the LIMA picture is taken in a rare situation. If there is a REMA, that you also do it before you do exchange. This is important, so we don't do multiple exchanges of the catheters when you're doing a diagnostic.
So the lesion is clearly severe enough, no need for any FFR here?
Yeah, actually, you know what, that's also a very important point, that the FFR and IVUS data, while we are very solid for the native vessel, where the even FFR for the vein graft has not been validated. Reason is that none of the vein graft trials or none of the FFR, whether DEFR or all the trials actually have eliminated patients with the vein graft. So we don't know what is the actual cutoff, even FAME and so, that cutoff for the FFR. But we still, in some cases, you can go with the 0.8, and I'll show you some data that maybe the FFR would not be applicable for the vein graft situation. But the point which Anu made, and this is what we say. Many times you want to be too aggressive in engaging the internal memory and not the PCI. I was just saying diagnostic, that you may create damage if you are trying to go too perfect. You don't need it. As long as you do a non-selective injection first, and then second, with the camera in a AP cranial, you are not moving it so that no pinch cushion distortion effect, so that you have a nice visualization and you are done. In this particular case, you need to be selective because you are planning to do a PCI. But just that is what our common teaching. One, AP, just AP to see the subclavian, and secondly, where the LIMA anastomosis, just that area. And if you need to go further, some question, then only you do go with a little more selective.
So, Samin, we normally ask Anu as to what she thinks is the technical challenges. Anu, you want to mention that now, or first let Samin?
No, this is I think this is the right time. And,
all right.
We can get back to slide and the technical issues.
Yeah, I think other one important also is this particular non-selective picture always helps if suppose we are going to do a LIMA intervention, what should be your guide catheter selection. So if it is in the horizontal portion of the subclavian artery, usually LIMA is the choice, your LIMA guide. And the same thing when you are doing LIMA intervention, depending on how tortuous the LIMA is and where the disease is, where 90% of the time the disease is in the native LAD, which means you have to go very further down. It's better you take a 90 centimeter or a 85 centimeter LIMA guide when you're doing the intervention. If it is in the upward part of the subclavian, maybe you can think of using a no torque guide to get into the LIMA. The challenges, I think what we see would be that the tortuosity in the groin, and many times there could be tortuous subclavian. So just getting the catheter, either your diagnostic catheter or your guide catheter, would be an issue, for which what you do is if you have a long sheath, use a long sheath. So many of the time your the groin tortuosity is taken care by the long sheath. Subclavian tortuosity may not be taken care. So in that case, what you do is you go with your diagnostic catheter, which is your JR, or if you have used a no torque catheter, get into your subclavian, and your wire is left in the catheter. And then what you do is most of the time either you have your regular wire, but we would recommend use a glide, a Terumo angled glide, and that you advance into the subclavian, then get your catheter into the subclavian, then you exchange to your guide catheter so that you can engage your LIMA. The other thing which you don't see in this particular LIMA is, suppose you have a very tortuous LIMA. Once you wire the LIMA, what you see your concertina effect. Many times as soon as you wire with your guide wire, you may see the LIMA going into spasm, concertina effect, and most important, what will happen, that patient will have chest pain giving rise to ST elevation. So very important that you have your diagnostic picture, keep that frame, so you are quickly able to wire then do your balloon and able to get your stent done. The third challenge would be even getting a balloon or a stent down, because LIMA has gone into spasm, or you have this kind of concertina effect. In the rare situation, you may use to have double wire, but have your devices ready. So first maybe just a 2O balloon, go down the LIMA, and then get a balloon result and get your stent down on your wire.
Anu, excellent points. Hopefully you can show us the maneuver with the Terumo wire also in this case. Samin, you want to take us through the relevant didactics related to this procedure?
Absolutely. So that we take it through. You want to do the other case first? No. Okay. Yeah. That the Saphenous vein graft intervention account for approximately 5% of all PCIs, with IMA intervention less than 0.5%. These are the latest data from the Cath PCI registry of ACC NCDR. Now, many of the intervention post-CABG patients is done in the native vessel. The very important that even if your vein graft disease occluded or stenosed because of degenerated segments, that we will go with a native vessel, so that truly the patients who have a graft and getting a PCI probably is about 8 to 10%, but only half of them we are working on the grafts, and other half of them we are working with the native vessel. Second, incidence of vein graft occlusion at 1 year has been reported to be anywhere from 15 to 50%. You say, wow, how can that happen? Well, this is actually the nice review. These are the various trials which actually have been published, and you can see at 1 year, once you do an angiogram, and based on whether it's off pump, on pump, endovascular harvesting, and so this has been criticized that the endoscopic harvesting has high occlusion, but anywhere from 19 to 40 to 50% occlusion of the vein graft is noted angiographically at 1 year. So that very high incidence at 1 year. In my opinion, after that it goes down a little less, and then by the time you get to 5 years, it's about 60%. And of course, we all know from the original Cleveland Clinic data that IMA graft patency at 5 years is more than 95%. Then question comes, what about the radial artery? And as you know, this field of radial artery versus vein graft has been under much debate, and it seems to be the jury is not out yet because of the prospective randomized data, but it seems to be that both are similar, but radial require a lot of preparation because a lot of spasm, so that we need to be handled very differently. And important for the radial artery is that how tight is your native vessel lesion. What has correlated that if your native vessel lesion is less than 80%, then your radial artery will prune out on the follow-up. So there had to be a very tight lesion when you are putting a radial artery. The third point, the redo CABG is associated with increased morbidity and mortality, and hence graft interventions are routinely done, because even if, or sometimes as I mentioned, native. Then vein graft intervention are technically challenging and are associated with higher peri-procedural MI, in-hospital mortality, and restenosis. Of course, then compared to the native vessel PCI, due to friable degenerated atheromatous thrombotic debris, and this has been the major issue. And then issues basically are because of the way we encounter these cases. One is the pathobiology of these vein grafts and LIMA, the progression of the non-obstructive lesion on post-PCI follow-up, and this is a very important point. This actually we learned back many years ago, the data from Alice, that untreated or treated, if you have a significantly moderate lesion left, that if you take these patients at follow-up, the many times the event rate occurs in the non-obstructive lesion. So therefore, the common dictum and teaching has occurred that while in the coronary, you go after only 70-80% lesion, that in the vein graft, when you are intervening, you try to seal and take care of the non-significant graft lesion also. To answer that question, there is a small randomized trial done called VELETI, using the paclitaxel-eluting stent, Taxus stent basically, compared to medical therapy, patients who have intermediate lesion or moderate lesion from 40 to 60% in the vein graft. The 27 patients have the medical, 30 has a paclitaxel-eluting stent, and you can see extremely better outcome of the patients who got the stent. So that seems to be contrary to the native vessel in the vein graft. There is some theory behind, and so at least some basis of intervening the intermediate and moderate lesion. And one of the big issue for the vein graft is, as shown in this slide, is basically the vasoconstriction of the chemicals, the thrombotic material, and the mechanical embolization. So that major issue has been shown that you have significant distal embolization. It's a very friable material, so that the trial of distal protection devices all have been very positive and has made to a class 1 indication. But I'll show you that even despite that, they're used barely in 25% of cases, even in this day and age. Now, predictors of adverse clinical events are basically slow flow and no reflow, CKMB elevation, high restenosis, and higher total occlusion. Now, then issue, as I mentioned, the graft versus native vessel intervention. If you have degenerated graft and you can go through the native vessel, should go through the native vessel. Occluded SVG, this is the board question. If it is not acute MI and you have occluded SVG, it's contraindicated for all purpose. You should not intervene on the occluded SVG. You should go with the occluded native vessel. Then issues, various technical issues with the vein graft. One is the direct stenting. Enough data have supported that in the vein graft, when you can capture the material downstream, lot of embolization occur by the pre-dilatation. So the direct stenting is preferred. So as much as possible in vein graft, of course, some patients with the calcific vein graft lesion, like patients with renal failure, your direct stent may not go. But every maneuver, every attempt should be made for the direct stenting. Then second concept is the small stent, which has been popularized by various people. Gus Prasad from Washington Hospital Center, showing that you put a small stent so that you keep just debris behind. But there are little concern of the distal high restenosis and thrombosis, so that this is the concept that in a 5 millimeter vein graft there is 80% lesion, you leave only 3.5 or 4 millimeter stent. And that's a concept which still need to be proven. Then clearly we know embolic protection devices, the proximal occlusion devices, pharmacological, the treatment of slow flow, no flow is very important, particularly nitroprusside, adenosine, nicardipine, all have shown to be beneficial in these cases. Then it comes a stent type. Remember the SAVE trial showed the BMS better than PTCA. So clearly that we need to do PTCA, we need to do bare-metal stent in the past. Then question came, can the drug-eluting stent be better than bare-metal stent? And this is a very, very controversial area. While the DES, in my opinion, kind of have taken the field and every trial that superiority over BMS, whether it be a left main, bifurcation, large vessel, small vessel, total occlusion, acute MI, that the field in the vein graft is still very controversial, and overall data I will support that the data for the drug-eluting stent. Then the covered stent, the old data of the covered stents were bad, but now we have this one new covered stent which is M-Guard, showing some big promise. Now this basically just to show where we are, how do we do PCI in United States in 2009. So this is 1 to 2 year data, majority of them we do it in the body of the graft, and about the 15-18% done at the distal anastomosis, some proximally. 2B3A, remember 2B3A is not shown to be beneficial in vein graft, yet in the country about 1/3 of the PCIs are done with the 2B3A of the vein graft intervention. And of course, once you use a DES, you have more complex cases, and success rate still remain quite high, over 96% and so. Now therefore, then you say, well, then it should be very simple. The DES we use, DES has been successful, but what really opened up our eyes is this risk trial and then the delayed risk, which is a 3-year follow-up. The risk is on the left side with the death, MI, TLR and TVR, in the BMS being the red and the DES being the white, and then you have 3-year data on the right side. You can see that while 6 months look quite good, and at 3 year, it's a contrary that there is a higher death rate, 30% death rate after the drug-eluting stent, while none in the bare metal. And that's really alarmed our interventional community, that how can that happen? But of course, they did have some advantage. Overall stent thrombosis was 1% in both the groups, and so angiographic restenosis was lower with the DES, but overall point was that you have a higher mortality. Then question was, why was the higher mortality? And they actually have identified all those 11 patients which died in the cipher group, and basically turns out to be that somehow the first generation DES have a very delayed endothelialization, which we know for sure, but in the vein graft even further delayed. So many of these deaths occurred when you stop the dual antiplatelet therapy after 1 year. These are the data on those 11 patients who died in the SES arm of the risk trial, that more than half of them were not on antiplatelet therapy. So there seems to be that if one group where you would continue more than 1 year of the antiplatelet therapy will be the DES in the vein graft. Then of course, then second trial is the SOS with the paclitaxel. You can see there is still a little signal of the mortality, and I would say this again deals with maybe a small stent thrombosis, although in the trial itself there was a lower stent thrombosis in the paclitaxel group, but at least this was not as bad as the risk trial. But key is still the question remains open, that which is better, DES or BMS, and I would say the answer to that is the major trial with a large number of patients, 600 plus, ISAR CABG. As you can see here, drug-eluting stent in red and bare metal in white. The key, and there is a stent thrombosis was again 1% in both the groups. So make sense that drug-eluting stent done correctly and with the antiplatelet therapy follow-up, that you do not penalize patients with late stent thrombosis. There has been some interaction of the vessel, the graft size with the drug-eluting stent, whether that in the small, medium-sized vessel up to 4 millimeter DES was better, more than 4.5 DES was not better. But overall, in my opinion, that if we can guarantee that patient is going to take antiplatelet therapy, DES remains. And this actually goes back to the recent meta-analysis published in JACC Intervention, that overall all-cause mortality, randomized trial and non-randomized trial, you can see there that some of the randomized trial favored BMS, but overall if you take all the registry, it still favored DES. And of course this is for the MACE, then recurrent MI, stent thrombosis is identical, same the TLR and TVR clearly favor the drug-eluting stent. And this is the population-based study which was just published last week in JACC Intervention, and taken again with the DES and BMS group of large number of patients, the larger risk kind in 1500 patients, clearly showing that the mortality is lower in the drug-eluting stent, survival is better with the DES versus BMS, all comers, MI was slightly lower in the DES group, and more importantly, lower restenosis. That's very important with the DES. And of course, the protection devices, should use it, but I showed you the data, only 25% in the ACC, NCDR, PCI registry, vein graft only 25% getting the embolic protection. Many of the trial actually are less than 5%. Even ISAR CABG, 5% of the patients got the embolic protection in that trial. And of course, the data we know it's supported quite well. Then issue is the covered stent. You will say, well, if embolization is the issue, why don't we put a covered stent? There were 3 trials, Symbiote 3, Barricade and Recovers. All trials were negative. Actually were harmful, higher stent thrombosis and so. But there is a newer design, and basically the M-Guard. M-Guard is the PET material, very thin stainless steel, a very tight mesh. And it's a bare-metal stent, and actually has shown in a small series of called INSPIRE trial, total 30 patients, half being the in the vein graft, thrombotic lesion, very low event rate. So whether it will really pan out to be the future, we need to see. But overall, it seems to be that some data of M-Guard are very promising to decrease the embolization and have a better long-term outcome.
Samin, excellent review. There is a question, I think, which is extremely relevant. It's coming to us from Australia, Dr. Costa Nicoletatos. I hope I'm pronouncing his name correct. I know he has been online with us before. What are your thoughts on left radial PCI to LAD via the LIMA?
Okay, that's another that's an important point, and this is exactly, I think, which we were going to mention in my technical challenge. That in a rare situation where there is either a diseased subclavian, stenosed subclavian, in this kind of situation, or really tortuous subclavian, that doing the intervention of the LIMA through the left radial is recommended, probably even easier in that particular situation. And just to show you what has happened is, despite us using a long sheath, and we could only get the guide.
Long sheath,
yeah. Yeah, long sheath, no, down, up. Yeah, that has taken out the tortuosity. Yeah. You see the long sheath.
Yeah.
But see our LIMA. This is the LIMA 85 centimeter guide.
And fit nicely.
Yeah.
And the key is the point made that when you are maneuvering this guiding catheter, leave the wire in the guide, and as soon as it is engages, then you slowly withdraw. Now many times, because of tortuosity, as soon as you withdraw your guiding the wire, whether it's a Terumo or that it may come out and may kink again. But this is basically so your long sheath, nicely stable guide, and then of course you go on further.
Anu, have you ever had the misfortune of having a dissection of the ostium of the LIMA?
Not dissection, but iatrogenic lesion created, means something that you try to go engage during diagnostic catheter. Maybe you lift up plaque, nothing happens, but then patient comes back and there is now a lesion at the origin of the LIMA. Like I told you, you rarely see any disease at the origin of the LIMA. If it is, then it is iatrogenic, caused by by multiple engagement at that level.
But we have seen enough, by others, not necessarily done, but we have seen it in our lab also, but I have seen a lot from outside. But that's a major issue, and I can tell you, I tell everybody, if you are looking at your hemodynamic when you are injecting the LIMA, you have a good tracing, that's fine. Most common cause of the LIMA dissection is that your the catheter is underneath the plaque into the subclavian, and you inject it and created the dissection.
Other also a very important point is when I showed you how you are doing your non-selective LIMA, very important that we teach our fellows, and what I want to emphasize, that as soon as you place your catheter, means as soon as you know you are engaged in your subclavian, first and most important that your pressure tracing has to be normal. If your pressure tracing is abnormal, you got to pull your catheter, and in rare situation you may have to go to LAO view when you know there's real tortuosity of the groin or your arch to really engage into the subclavian to understand where the subclavian is originating. And once you are there, make sure pressure tracing is good, then only you take a picture, because if you have diseased subclavian, you know your first injection could be a dissection of the subclavian.
So definitely not the assist device kind of cases.
No.
I have seen rare cases of dissection with assist in the subclavian and the LIMA.
Yeah.
So we use the assist in few of our rooms here, and I teach all of them, our fellows here, be extra careful.
You have to be very vigilant when you are doing subclavian and LIMA, that if you are not careful, not paying attention to the pressure tracing, you do more harm.
Yep.
Anu, ever had situations where needed a non-LIMA guide for LIMA interventions?
Yeah, means you could probably do your with the no torque, or sometimes even your JR catheter, your FR guide.
But all soft tip with very careful manipulation,
very careful.
watching the hemodynamics.
Yeah.
Excellent.
Then the same thing, you might have tried couple of guides, and then you just cannot get into engage the way we are engaged. You just cannot engage, but you are there in the subclavian. So in that situation, what we would do, just leave the guide in the subclavian and make your curve of your any glide wire that you are going to use, just like a big hook, so that you'll be able to wire the LIMA with the guide just in the subclavian. Excellent. That you are not engaged, and once you are wired, then you can counterclock and then get your guide selectively engaged into the LIMA.
Basically using the wire to steer in the guide very gently. All right, Anu, bivalirudin here?
Yeah, bivalirudin, and our ACT is 312.
What is your thought about 2B3A use for LIMA? Same as for PCI, or any different, any greater use or less use?
Yeah, no, actually, basically the LIMA we still be a little more, I would say, open in terms of using the balloon.
Okay, yeah.
The open using the 2B3A, but definitely in the vein graft, we almost have gone away, because initial data, as you remember from the EPIC and epilogue, when they combined, they actually found in the 5 trials that 2B3A had a higher event rate. But there are data from the SAFER that use a distal protection. Using the 2B3A, you had a lower event. So the 2B3A and the distal protection did have some benefit, but overall not in the vein graft. Now, in the LIMA, our use is, overall in our lab, 2B3A is about 15-18%. Same will be in this particular case. If we see some slow flow or some difficulty, we'll use it in those 15-18% of cases. Lesion by itself is not asking for, in my opinion, of the 2B3A. Some of the cases like left main, bifurcation, complex calcific lesion, will use 2B3A. We rarely use 2B3A as a bailout. It's usually we decide what we are going to use, and usually it's a 2 bolus of aptafibatide. And same thing, actually, the data itself of the bivalirudin are very weak in terms of any special benefit in the vein graft. If you saw originally, actually, in the when the vein graft intervention were being done with the brachytherapy, and so there were some cases reported bivalirudin causing more thrombosis to the FDA, so that people felt that maybe it's not a right drug for this purpose. And therefore, the sub-study of the acuity of the vein graft was no difference in all the 3 groups: bivalirudin alone, bivalirudin plus 2B3A, and heparin plus 2B3A. So that even bleeding was slightly insignificantly lower, but the MACE point of view, it does not have any special advantage. Why do we use bivalirudin? Clearly, I tell everybody that we are using bivalirudin only to decrease the vascular complication. knowing that by your technical tips, you will do better, that you will decrease the overall event rate and complication of the intervention, and in about 18-20% of cases, you will use either pre-planned or bailout 2B3A to get a good results.
Excellent points. I mean, Anu, routine nitroglycerin would be a overkill?
Yes, I think more important for LIMA may be verapamil.
All right.
Have your verapamil and nitro ready. Like I said, I think other important, two important things that you need to be ready is that you do your angiogram, and then wherever the lesion is, I think you have to picture it in your mind. Pay attention to the LIMA clips and your sternal wires to know exactly where the lesion is, for the reason I mentioned earlier, that not in this particular case, but if you have a very tortuous LIMA, as soon as your wire, it may go into spasm or the concertina effect, no flow, ST elevation, and you are there. The goal should be quickly wire it, balloon it, stent, and come out. So be ready with your devices beforehand. So in this particular case, if you see there, we have just one circle of the LIMA there, and then the lesion is after the attachment. So you can see two clips. So as long as we know, there's somewhere at the level of the two clips in this particular view, that's where your lesion would be. That if there is any problem with the LIMA, if they have not clipped the LIMA, also what can happen is when you're trying to wire, it may go into all small branches of the LIMA. So many times what you need to do is you will have to wire it, like here it was going into another small branch, we were able to wire, but then you will need your balloon support to actually negotiate your wires. So now we are going with the 2520 balloon, so that we will be able to get the wire down, again making multiple curves there. Now the guide has come out, so you may have to engage the guide.
Yeah, in these kind of tortuous cases that you are not going to put a direct stent,
yeah.
So go with the balloon support. My teaching, my fellows start doing it, this case without the balloon support, trying to advance, because what will happen, your guide will come out, you are pushing the guide again, you are giving the dye unnecessary. So go with the balloon support, because that's what you are going to use anyway. So that in this particular case, now we are going to the other view now, that if you're going without the balloon support, in my opinion, is a negative marks.
RAO 923.
I mean, excellent illustration there. And as you had mentioned, each time you're making the manipulations, you're watching the hemodynamics very closely.
Yeah. So as we know, many times what happens is, I think with the wire and balloon, you're trying to get into the native LAD, your guide, comes off the ostium. So many times what will happen, that you'll try to give the dye, but you won't see anything. That is why you need to have your picture, photographic pictures, knowing exactly where the vessel is and how you're going to wire it. No, I think we're okay. Now in the apical.
Wonderful illustration of there you go, the wire nicely doubled up there. Now you have
now
all
we
the
know
support.
this is exactly what I'm saying. We are not giving any dye, but based on the angiogram, we know this is where the lesion is. You see those two clips in the V shape, that's where the lesion is. No dye, and we saw that.
And what is the balloon?
Very
this
soft,
is a 2520.
Very soft lesion, huh?
Yeah.
2.520 apex.
So, and we will have our stent ready 27528.
28, 23.
So
23?
Yeah, or 28 will go.
23.
So Anu, what you mentioned here, the two important points here is also the critical need of road mapping these lesions.
100%.
All right.
Road mapping for two reasons. One, you may not be able to give the dye. Second, patient may become unstable, so you are able to do your intervention quickly.
Did you feel the balloon length could have been a little shorter?
No, this is a 20 millimeter
okay.
balloon.
No, but could be lesion, but point is, as long as your stent, we are trying to put a 23 or 28 millimeter, so that it does not matter. Usually like.
What stent are you planning to use here, Samir?
It's a 2.75 for 28 millimeter Zions.
All right.
You want to go to the second bend or just?
No, but just 28 will cover both that little hump.
So even here now, you're not going to take a quick picture to see?
Yeah,
or,
we definitely.
You will, okay.
This one, yes. Now, many times just because the wire is there, you may not be able to see much.
Yeah.
And I always also advise people When they take a picture with a balloon there and they are worried about little dissection, little thrombus, they don't take a picture when the balloon. I always, in my opinion, that's absolutely no-no. They take the balloon out, even of the lesion you could leave in the vessel if you want, but you bring it to the guide catheter. Yeah, good.
You've ever done rotational ablation through the LIMA?
Yes.
We actually,
Yes, I think in that situation you have to get your burr in the LIMA. You have to negotiate the LIMA by dyna. So
Right.
then you go to your distal anastomosis and then you start your burr, usually 125 or 15. But what you do is use over the wire balloon or any transit catheter. Go with the regular wire, then change to rotawire. Don't try to wire the LIMA with the rotawire.
275 or 30?
This is a 275.
275, but you may need to post dilate to a 3020 high pressure balloon. And
Now
we'll
same
take a
thing,
contact
the stent, length. Since we, okay, look at how it's negotiating.
And as you can see that we are not looking at the guide.
Yeah.
Because we know the distal wire, and you saw how these second generation thin cobalt chromium stents, very nice illustration, took a full 360-degree turn and came out without any problem. If there is some issue, sometimes you may end up using a second wire as a buddy wire technique, but otherwise take a picture here. But there is another, the one field ongoing is that called concertina effect of these thin stents. Basically that at edges they become closure, and this a lot has been talked now in last few weeks because of the papers in the Euro intervention. No, looks good. Yeah.
You won't be able
That's
to
good.
see that?
No, that's good.
Never needed to use a
Good.
7 French guide, have you?
Yeah, that's fine. Fine. Yep.
Yeah. 7 French?
Never needed to use it,
No,
have you?
no.
Okay. So this is, so you're going to deploy at what, 12?
Yeah, 12.
Yep.
Unless we are doing a planned, double stent technique, I would say our intervention in Mount Sinai Hospital are all done with 6 French or 5 French.
Samin, you mentioned data on the M-Guard. Have you had a chance to use it?
No, actually, but very interesting, very impressive. The data in the acute MI setting, they actually have the patients in the acute MI setting also. The acute MI setting working quite well with a low restenosis. I know they are starting the trial out of US, and then some of the trial, this Israeli-based company, they have done some work in Israel.
That's the PREVENT trial, no?
Yeah.
With OCT follow-up.
Right. That basically it makes sense, but how it's going to happen with the bare-metal stent, that's a big issue. And more importantly, the cost of making apparently M-Guard stent is like 3 times than you do with the drug-eluting stent. So they're trying to figure out what will be the DRG code if we use and this device is successful. But very excellent data in acute MI setting, thrombotic lesions, and of course the vein graft. But some ongoing further trials will answer this question a little more. And same thing with the BMS and DES. Still there are a lot of trials ongoing now with the large trials of the vein actually it's looking very good in terms of the size. Look at this.
Yeah, looks
I think we don't need to post dilate.
Yeah. Anu, I was, when you removed the stent, I normally at that time I'm watching the origin of the LIMA. Not needed most of the time. You feel it was tracking well enough?
I think we are watching the pressure. If we
Got
see
it.
some
Excellent.
damp in the pressure, then I know that something is happening at the ostia.
So what, you're going to post dilate here?
No. I
Leave
think
it
we are
alone.
done.
I mean, should we?
I don't know.
What's the courtesy?
You know,
Want to do IVUS?
12 atmosphere should be.
Let's, no, if you want to post that, no.
Why not IVUS? I can tell you, we have not done the IVUS of the LED via the LIMA, but maybe we, do many things in life first time. Maybe this one, this will be the good concept, because as you know, that we are not, because of the lot of plaque debulking we do, many of the cases, we will just deploy particularly these generation stents.
You think in the mid 2/3 of the stent, that's a tiny little branch coming from the superior surface, or is that a...
Yeah, that is a tiny little branch, and we are going to take a picture in another view.
Anu, what is going to be your dual antiplatelet strategy here?
This patient is already on aspirin Flavix.
Yeah.
I think we just continue
For
on that.
how long?
They will be for 1 year.
Yeah. I think the
Because
vein
they are,
graft, yeah.
the Zions in her native vessels also.
Yeah. I would say that there is,
1 year from today.
yeah, that particularly in the vein graft, DES, I think because of this further delayed endothelization, there is a reasonable data to support that maybe in those cases you do a longer, but this one I'll treat it as a native vessel. It's a very nice results and good stent position. Should you go to a high pressure? Not routinely in our lab, but sometimes it may be needed. We can do, but it's a nice expansion. I think this will be another good example if we can get without much trauma. AK here. That put this IVUS catheter, but if we see little resistance in these because all these devices are okay, but they do have a very insignificant penalty of causing the damage. Even in the prospect trial, that about 1.2 or 1.4% of cases did have the IVUS related injury to the vessel, iatrogenic. So that we always need to be careful. So that particularly with the vein graft, with the tortuosity, they will just try to see.
Samin, in your
Yeah,
previous years, you've been quite bullish about the angiojet for vein grafts. You didn't mention
Okay,
much
let's
of
go.
that today.
Start.
Yeah, actually, I would say that used to be in the past.
Okay. Yeah.
Yeah, and I'll just talk about that in 1 second. Yeah, this is now we are distal LED beyond our stent. And we are coming back to the stent now.
Huh?
Okay. Good stent opposition.
Yeah, look at that. See, this is the concept which we say that you lesion preparation and this area is. But the stent is well opposed. Could he get a little more expansion in some segments? Yes. Yeah, I think we can dilate with a 3 or 20 high pressure. Good. Let's take it out.
Okay.
Yeah, in that area. But
Yeah,
key is the two things: stent apposition and stent expansion. So by all means, the stent is very well opposed, as you saw. Now then, question comes back: is the vein graft and the angiojet and so? It turns out to be, as you see, that the trials of the vein graft, of course, the old one with the AMI, which we knew, and then
The jet stent.
the jet stent trial in now with the myocardial infarction, with a very small percentage of cases being the vein graft, so that the angiojet for all purposes, in my opinion, has gone away from the vein graft intervention. Now, we used to use quite a bit. You know, many of the angiojet now we have used that we have done the easy filter, and now you see the filter clogged up. So there you have two choices. Yeah, that either you use angiojet or your export catheter to remove that debris. And those are the cases which we actually have done angiojet. Otherwise, majority of them,
Go.
yeah, that angiojet has been we are not using the angiojet in the vein graft. So now remember it's about 3 millimeter vessel. So that now I've brought a 3020 quantum apex.
NC Voyager.
NC Voyager, and we have gone with the 18 atmosphere in that proximal part, not distal. Distal was very well opposed. We don't need to do anything
Okay,
distal.
good,
Yeah,
yeah.
here. And the proximal one, and I know we started about 4 or 5 minutes late, but we are very well within timing. In next 2 minutes, we'll take a picture and complete this our case for today.
Samin, just to a little off the topic, but some very relevant recent publications at the JACC about the functional syntax score. Are you people considerably using it, employing the FFR for that, or what is your strategy at the moment?
Yeah, the functional, the syntax score, actually, it's very interesting. The part of that has become that many of these syntax, that many of our 3-vessel disease become less. Though I would say that to me, that is some data, but that is when if you want to say that you want to do the PCI in those cases. But otherwise, I think the concept still remains the same. And the concept basically is that if you have overall syntax score, the high should go for surgery, But even if by functional you have decreased, I think it will just going to let you know that you can do safely the intervention in those lesions and is indicated. Now, what is more important is the ASEF, which takes into account patient's creatinine, and actually we are writing our paper, the age of the patients, the sex, and the ejection fraction. The Jason Kovacic, actually we have done our 500 patient paired, and we have compared with the various kind of scores, and he can maybe speak for about a minute about our work on this 500 patients.
Is he stable enough after losing the rugby to New Zealand? I hope he's recovered from that.
I think I've recovered from the rugby.
Yeah, the last I heard, Sydney was in Great Depression.
Let me finish this.
Great depression. We've got to let them win a few things.
We need to, Jason, little volume, we need to slightly improve it. That's the NBA player. Let's focus up there. There you
focus,
go.
Higher up. You may lose us now.
No, but you want to finish it? Anu just had to say last point, and then we will get him on this. So yeah.
Anu, also a little touch of myocardial bridging there in the mid portion.
Distal. That always happens with the LED
Stent,
intervention. I think what have now you see here how we took our final picture. You take your wire out, okay, and then you leave your wire at the origin of the LIMA, just because if you take the wire out completely, many times the engaged guide comes out. Now you are spending another 3-4 minutes to engage the guide again. Many times you may have to use your wire to get back into the subclavian. So that is why your guide wire stays at the ostium, but take out the wire from the rest of the LIMA, and now we are taking the picture of the entire LIMA and the distal anastomosis, including the LED, making sure that we did not cause any damage to the LIMA during this procedure. Now, this is exactly what your question was, that we were not paying attention to the ostium or the origin of where the guide was sitting, but your final picture we got to document that was no iatrogenic damage caused by us.
Anu, 2 questions more. You also have to be very careful when you are removing the balloons after stent deployment, so that it doesn't suck in the guiding catheter, no?
Yes.
Yeah. I think with this second generation stent, we usually don't see that sticking of the balloon, which we saw with the first generation DES. In that we really had to be careful, and we know that it's not separating. You will have to disengage at the ostium, which means you have to move your camera again, look at the ostium, and then take your balloon out.
Any special maneuver when you are removing the guide?
When you are taking the guide out of the LIMA, counter it.
Yep.
Okay.
Counter and then take it down the subclavian.
And don't advance the wire. Many people will advance the wire through the guide catheter. No, just little counter and you pull it out. Will come out without any problem. And the same thing is that the DES, BMS, or you should have a first versus second generation. We actually at Mount Sinai in about 200 plus cases, our fellow Bhushan Sharma actually had done the analysis. We are sending that abstract for ACC, and knowing that we are still creating the data, it seems to be that the first generation DES, because of their rigidity, had a lower outcome even compared to bare-metal stent in this LIMA intervention, while of course the second generation stent remain the best. Yeah. Now maybe Jason complete this issue about the syntax score and many of these risk score which are popping up. Every other week I see journal, they're coming up with a new score, the global score, the Euro syntax score, SF, you name it. There's so many scores have come out to predict the patient's outcome. Maybe if you can give us 1 minute summary.
You have not created the Mount Sinai score yet.
We're working on that next.
Working on that's the
Look
next.
out for that. So the thing with the syntax score, as we all know, is very good. It was done on a group of patients that were fairly homogeneous, so that it was, as you know, it's used to triage patients to bypass versus PCI. But what the syntax score doesn't take into account is other comorbidities. So if you have a patient with a syntax score of 33, 34, but they're 80 years old, they've had a stroke, their creatinine's 1.6 and things like that, you know they're not necessarily going to do very well at bypass. And so there's been push towards integrating some clinical risk factors, age, creatinine ejection fraction, into this clinical syntax score and other scores to really give us a better feeling for who's going to do well and who's not going to do so well after PCI or after bypass. So recently this ASEF score, which is age, creatinine ejection fraction, there's a modified ASEF, there's a clinical syntax, there's a New York State risk score. We've undertaken a cross comparison of all these 6 scores. And really what comes out is that if you have high-risk patients going for PCI, the traditional syntax score doesn't do a very good job at predicting who's going to do well after PCI, because it just doesn't take into account those other risk factors, which we all know clinically is so critically important. And it turns out that, in fact, just taking the pure syntax score on the anatomy alone is one of the poorest scores for predicting overall mortality and outcomes. It does very well at predicting TLR and TVR, but when you're 80, that's not necessarily the most important thing. It's your age and other comorbidities. So that's something to look out for in the future, and perhaps it'll be something that we move away a little from the traditional syntax score and start bringing these other risk factors into the equation.
Excellent job, Jason. Samin, a quick question from you coming from Canada. Dr. Firas' question. Great job, bravo. Is your patient under general anesthesia? She's very quiet and wise, I see.
Thanks to our nurse, Vicky.
Vicky and
Show her.
Christine.
Where is she? Where is Vicky?
Yeah,
Vicky.
but that's a great, and you know, we have
And
emphasized
Christine,
that repeatedly in our symposium also, that nurses, they have full power to bring the level of conscious sedation as required during the case. So they keep the patient knowing that patient has to be in la-la land, not the anesthesia, not awake, but be in la-la land, and they keep the great job. With that note, we go to the last slide, because we got to exactly our 60th minute, that LIMA, the take-home message in the bypass graft intervention. The LIMA SVG interventions are technically challenging and require careful technical consideration as regards to guide catheter, embolic protection, device manipulation, and vasodilators. And I would say this case was a prime example, and you saw how beautiful and fantastic results we got in this case. Then overall data support the use of DES in SVG intervention, provided patient is on DAPT compliance that continue long term. Third, or final message, that second generation DES, similar to native vessel PCI, seems to have superior outcome compared to the first generation DES, because at present the trials are ongoing for the Promus SOS and so to show the data of the second generation will really show a long-term benefit, not only just in restenosis, but in decreasing the overall myocardial infarction. May not be in death, but definitely the death should not be higher as long as patients taking a dual antiplatelet therapy. And similar data we are noticing in our LIMA intervention.
Anu, final message from you.
Yep.
Oh.
Yeah, no, you wanted to say something, yeah.
Anu,
In my intervention, we've randomized the group into a PCI, bare-metal stent, first generation stent and second generation stent. And in terms of TLR, TVR, MI and the total mortality rate, we found second generation DES to be superior, though the number is about 300 over a period of 5 years.
Great. Anu, last message. And
I think the last message is when we are doing a LIMA intervention, the tips and tricks that we have shown, just be prepared, have your devices ready, and the worst thing that could go wrong is the spasm of the LIMA. So as long as you know the intervention has to be done, have your steps 1, 2, 3 ready, and once you start the case, be ready to finish it and come out. And your vasodilator should be verapamil connected to your manifold.
okay.
Thank you.
With that note, we'll see you all next month.
exactly on time, Samin. Excellent job. Congratulations to you and your team, to Dr. Bhushan, Jason. I hope you have found it instructional. Hopefully some of these teaching tips how to handle LIMA interventions will be useful. We'll see you next time, November 15th, for our next session. Till then, goodbye.